Hello and good day to you. This is Tracy Harrison from the School of Applied Functional Medicine, and I want to invite all progressive healthcare professionals and practitioners where we offer functional medicine best practices, myths, missteps, and insights to serve your clinical practice. Certainly a topic that many of us embrace in our practices is using supplements as tools. But like any other tool, it can be used effectively, used ineffectively, used not enough, used too much, used in ways that are actually counterproductive. And so today we're going to be diving into the world of both missteps and best practices. What are advanced supplementation insights that practitioners really need to know in order to maximize the clinical utility of the supplements they choose to work with? Here at SAFM, we have both the pleasure and the privilege of supporting practitioners around the world. Our actual student body currently hails from 75 different countries around the world and 22 different professional modalities, and you are all very welcome here. I want to jump right in with an overarching concept that is going to seem very straightforward to you, and you might even say obvious. But like so much else in life, it is often the obvious points and considerations that also are the ones we easily and perhaps frequently overlook. And this has to do with, why do we use a supplement? Now, this is very interesting because supplements, like any other tools, can be really quite helpful. But just like a hammer is not going to be very helpful where the optimal tool is a shovel, right? Sometimes we use supplements in inappropriate or contraindicated or even just counterproductive ways. And I think it's really important that we as practitioners be very focused when we recommend a supplement on, why am I using this? So we teach at SAFM that there are 3 specific reasons why you would want to use a supplement. And it's important to not only be clear in your mind why you're using it, but to teach your client why you're using it. And I'll tell you more about that in just a moment. The 3 reasons are, first of all, rapid relief. In order to help someone to experience symptom relief because they are getting some kind of temporary support for maybe a physiological process that is inflamed or a biochemical process that's not being well fueled, it's about giving them some rapid and immediate relief. And you know, it's interesting, through the functional medicine community, some practitioners are quick to downplay or even poo-poo any focus on rapid relief or symptom relief. And for sure, we don't ever want to limit our practice on just providing symptom relief, because in many cases, as many of you seasoned practitioners know, you can do a lot of things to provide relief that aren't addressing the root cause of a disease dynamic at all. And so they're 2 separate things. But rapid relief is actually really essential. I think it's a misstep to not prioritize it in your clinical engagements, because rapid relief galvanizes your patient, right? Even if you know deep down rapid relief is just the beginning, it's not addressing root causes. But here's the thing, your patient is suffering. And rapid relief helps, first of all, to galvanize their confidence in you as a practitioner in whatever modality you are practicing in. It helps them to see that you do indeed have some tools they can benefit from. You do indeed have knowledge enough of their particular pattern of suffering or disease etiology that you can help. This is important for building trust, building rapport, building an ongoing, hopefully longer-term relationship with a particular patient. So we've got to galvanize their trust in you. But the other thing that's really essential, especially in the realm of functional medicine, is you've got to galvanize their belief that they can feel better, period. Many people who come to us in the realm of functional medicine, regardless of your modality, have been suffering for a long time. They're wrestling with something that their conventional or traditional provider can't address, or has only been able to treat and maybe provide some temporary relief, or even worse, it's been treated for a long time and the very pharmaceutical interventions they used have worsened the disease process over time, which actually happens with a lot of drugs, actually, that can be very helpful up front, but they have long-term implications. There, of course, are implications of suppressing what the body naturally wants to do as a primary intervention strategy. But people have been suffering for a long time, and so many of them have become jaded, disappointed, maybe even worse. Maybe they're depressed, they're almost hopeless, they're barely hanging on. They may be angry because they've been suffering for so long, and they may be on the verge of giving up. You may be not only the second, but maybe the 5th or the 10th or the 15th person they've told their story to, that they are hoping finally has the ability to actually help them find some answers. And so it's really essential that we counter that perhaps entrenched nocebo, naysaying, belief giving up, belief that they have about their body and their physiology. And so we've got to create some small wins. We've got to create a positive expectation to counter their history, which may have been really demoralizing. So rapid relief matters, but the supplements you would recommend for rapid relief are very often not the ones that they need to keep taking on an ongoing basis. So we might recommend one thing for rapid relief, but then the second category to consider is an actual intervention to reverse the disease dynamics that they're struggling with. A great example of this is antimicrobial herbs, right? Maybe a person has a certain type of dysbiosis. They're struggling with a yeast or fungal overgrowth, or maybe they have a opportunistic bacterial overgrowth. Maybe it is H. pylori in the gastric cavity that's causing gastritis or acid reflux. Of course, people may need some type of antimicrobial intervention along their healing path, but that's not something we want them to keep taking forever. But here's the thing, if you don't tell them up front, this is what this is for, and this is the expected duration of using the supplement, the typical patient is going to assume, if it helped me to feel better for a couple of weeks, then I should keep using it for life. And I can't tell you how many people I've worked with, even in our multimodality practice, who are still taking things that were recommended to them 10 years ago. Not much less 2 or 3 years ago, because they're afraid to stop them. And they're confused and they don't actually know really what it was for, or they were told in general, this is for my reflux. And you ask them, so what specifically do you believe it's doing to help your reflux? They don't know. This is a failure to educate your patient, an essential component of helping people to get well and stay well. Because if we don't educate them on specifically what it is doing, not just that it will help, you should take it, in an effort to get them to be compliant. We want them to actually be galvanized and have an aha around, oh my gosh, this is going to address this thing, which is helping this thing, and so it's going to relieve this thing. And then they have this epiphanal aha that says, wow, I actually understand what's happening in my body. Not only do you know, you're actually able to teach me in language I can understand with simple stories and analogies. And oh, by the way, you care enough about me to make sure I'm educated. And then when people get educated, they get inspired, because now they think, okay, I could actually be a participant in my own healthcare, because I don't feel like I have to maybe be fixed by you. I feel like I'm a partner here. Getting to the point where you have a savvy clinical partnership is everything around helping someone not only to get well, but most importantly, helping them to stay well. And if they feel like everything that's happening in their body is too complex, over their head, impossible to understand, don't even bother, then they tend to be compliant as long as they are deeply suffering or as long as they are afraid. But then when they start to feel a little bit better, and when they start to not be so fearful anymore, the things like supplements, things like lifestyle changes, dietary changes, exercise or sleep habit changes, they fall by the wayside, because the way they saw your recommendation was through the lens of a fear or through the lens of a suffering. If they see it through the lens of education and inspiration, empowerment, and get on fire to take back ownership of their own health, then they can be set on a long-term course for health, because they see the power of their own autonomy, their own health oversight, as being valuable and even sufficient for the long term. So there's lots of different interventions that might be of value with supplements for certain periods of time. Now, this may come into play with things such as nutrients that are depleted by medications. And I'm going to talk about that in great depth in just a second. So if you're passionate about that one, please stay tuned. But you might recommend a CoQ10, ubiquinol, right? For if a person is taking a statin medication. And certainly you may be on a mission to help them to reduce inflammation in their body, to improve their lipid profile, etc. So they don't need a statin anymore. But in the interim, you definitely want to be addressing the fact that the statin drug is overtly depleting CoQ10 in their body, which is an absolutely essential antioxidant internal to our mitochondria, and also participates directly in the electron transport chain component of how our mitochondria actually generate cellular fuel. You might recommend an antimicrobial to counter a dysbiosis. You might recommend a gastrointestinal binder if people are doing a targeted detoxification type of regimen. You might recommend a certain herbal agent to better help with reduction of symptoms due to hormone imbalance. And again, eventually you want to correct the hormone imbalance, but in the interim, while you're working on a step-by-step plan, these are the types of things that can really be of value. But again, all of these things, whether it's an herb or a nutrient or some other, protein or amino acid, they can have negative complications if we take them too much or if we take them too long. And so it's important to at least estimate. We'll see how it goes, but I believe at this point that you will need this and benefit from it for about 2 to 3 months. And then after that, we'll be able to move on to the next stage. Well, the person is taking notes, right? They understand, they have in their mind, this is temporary. Again, if you don't tell them that, highly likely they're still going to be taking it in 10 years. The last category of supplements is what most of us don't consider in a plan when we're working with people, but it's the thing our patients tend to assume if you don't tell them otherwise. And this is that a supplement is a maintenance supplement. And you recommended it to me, so I'm going to take it forever. I'm going to take it for life. Through all the phases of my life, all the changes of my life, I'm going to keep taking berberine. I'm going to keep taking Vitex, right? All the way through my menopause. 12 years later, I met with a woman who's doing very well hormonally on menopause, but she's still taking Vitex or Chase Treeberry because it helped her 20 years ago when she was first entering the stages of perimenopause, because she'd had a long-standing history of PCOS. And so I'm sure that supplement made sense at the time, and it probably helped her for a period of years. But now she's in a completely different phase of life with a completely different set of disease dynamics at play, and so she needs different targeted interventions. But no one ever told her what the Vitex was for. No one ever told her what to expect from it. No one ever told her about how long should I take this. No one ever told her when it would be logical to stop, even if after they cease their patient engagement with you, right? They move, they go to another provider, you move, they can't afford your services anymore, right? You retire, all of these things. People will keep using the same old supplement. So I spend time on this right up front because I get it. It seems very simple and straightforward, but you'd be stunned to learn just how common this is. We have the privilege here at SAFM of supporting thousands of healthcare practitioners. So we see a lot of these underlying missteps and missed opportunities across modalities, even around the world, that practitioners struggle with in going from the wisdom of functional medicine science to its savvy clinical application to actually maximize outcomes. Obviously, those are two very different things. But I promised you that I want to talk about nutrient depletions for medications because this is an essential topic that is something that many practitioners have never been educated about. It's something that I think in particular pharmacists are in a fabulous position. Even if you're working in a retail pharmacy environment and you're learning about functional medicine and maybe you have eventual other professional aspirations, you can begin to add massive value through the functional medicine lens right now, today, even in a retail pharmacy setting. But I'm so excited that pharmacists are getting passionate about functional medicine, because I think there are many different business models in which pharmacists can be unbelievably effective and impactful on their own, but also in collaboration with other practitioners in the realm of functional medicine practice. But in teaching patients when they pick up a prescription about what some of the possible nutrient depletions are, and some of them are less common than others, but let's talk about the oh so common ones and also the ones that are most likely to show up quickly. And I already mentioned statins and CoQ10, and I think that is that's one that often tends to be well known. But let's look at other popular medications. What about beta blocker drugs that are still in widespread use for hypertension, especially for stress-mediated hypertension? These medications have also been shown in research to deplete CoQ10. Well, this is a real problem, because people who have hypertension usually have challenges with redox imbalance, right? Where they have too much oxidative stress and damage, especially in their blood vessels, their arteries. And while that may be specific to nitric acid in the arteries, what we're struggling with hypertension is cellular dysfunction actually in the cardiovascular system. And we have to be able to fuel mitochondria and living, the normal act of living and breathing and going through cellular respiration generates a lot of oxidative stress. And we must have good, consistent, sufficient antioxidant function. And here I really want to focus on endogenous antioxidants. Not the things we supplement with overtly. Those can be valuable, but the most potent, the fundamental antioxidant function that humans need and thrive on comes from our own endogenous synthesis of things like glutathione, of things like superoxide dismutase, of things like melatonin. Beta blockers also deplete melatonin. Well, considering melatonin is one of the most important antioxidants to flood the body with every night to heal our arteries, that's a terrible pair up with regard to medication, in particular depletion on the other side of that. But we need to be thinking about a unique patient's vulnerability to having their melatonin and their CoQ10 levels driven down based on a medication choice. And we want to be ready for what are the coincident supplementations that we need to consider to support that. Or maybe it makes sense to use a different medication. But in this particular case, we're talking about two nutrient depletions that are actually in the way of healing, right? If a person has hypertension, we want them to have optimal levels of CoQ10. We want them to have optimal levels of melatonin. So this is an important consideration. Another oh so common drug, it's so common in fact that a lot of the patients don't even think of it as being a drug, it's just something they take every day, and that's oral contraceptives. Research shows that ongoing use of these can deplete potentially a number of nutrients, but by far the one that is not only most commonly depleted, but also the most readily depleted is vitamin B6. Another problem, because vitamin B6 is essential for the transsulfuration pathway that gets us from methylation to the synthesis of glutathione. And we must be able to methylate well in order to have good estrogen metabolism, right? Good estrogen biotransformation. In particular, we need to methylate estrogens to make them less carcinogenic. It's a good reminder, most hormone imbalance that women struggle with in particular, is less about ovaries gone wild and more about impairments and blockages in appropriate biotransformation and excretion of hormones like estrogen. And inadequate nutrients can be a key player for that. And B6, the very thing Often that birth control pills are being prescribed for, right? Really horrid PMS, highly debilitating menstrual bleed that's leading to episodic monthly anemia, these types of things, right? We want to be able to metabolize estrogens well, and we need vitamin B6 in order to do that. We need B6 to make glutathione, which is part of what protects our tissues from excessive estrogenic effects or from excessive oxidative effects that can actually do intracellular oxidative damage and perhaps increase our predisposition for hormone-mediated cancers. So there's some interesting, we call this interconnectedness, right? Where taking a medication can lead to a nutrient depletion that can lead to inadequate cofactors for a very specific enzyme, in this case, let's just say to make glutathione. So with suboptimal levels of glutathione, then we may not be able to do appropriate intracellular antioxidant function. So we get more intracellular oxidative damage, including in the nucleus and to DNA, which makes us more vulnerable to carcinogenic effects. It's a causal chain, right? A step by step by step. We call this a chain of interconnectedness, right? And you might be shocked to find out how often medications are involved in that chain. Now, this is not to speak negatively overall of medications at all. Far from it. Medications can be incredibly powerful tools, and in particular, essential aspects of rapid relief and at least taming a disease process so that a person doesn't further damage a body part or lose a body part or die. Really essential components. The functional medicine lens in general honors that place of pharmaceuticals, but certainly transcends the notions that they should always be first line remedies and certainly not singular or solo remedies or the end of the story. Because we know that by diving into the interconnectedness in a unique case, we can nearly always do better. We can nearly always do better and actually get at the roots of why that person has hypertension, or why does that person have terrible menstrual period experiences. Let's address the roots and actually make it go away so that we don't even need to worry about this particular interaction. I could go on and on, right? Diuretics, especially hydrochlorothiazide, depleting electrolytes, including magnesium or even potassium, which again are essential for keeping optimal blood pressure, which is what those medications are so often prescribed for. Proton pump inhibitors, purposefully lowering stomach acid, so basically purposefully breaking digestion, which can impair our ability to bring into the body key amino acids and nutrients like magnesium that we need to not have acid reflux in the first place, which was why the PPIs were prescribed. You can see, again, some of this interconnected causality and something we need to be thinking about. Metformin. And keep in mind, I'm talking about the blockbuster medications right here, right? The oh so commonly prescribed ones. The list goes on and on. Metformin, it's been known for decades that it can pretty dramatically deplete vitamin B12 in the body. Well, B12 is essential for a number of different functions, but in particular for the health of our nerves. B12 is essential for the maintenance and repair of the myelin sheath on our nerves. Well, what is a known side effect of type 2 diabetes, which is why people might be taking metformin in the first place? Oh, neuropathy, because of oxidative damage to our nerves, in part because of hyperglycemia. And so our nerves are already struggling, and now we're going to take metformin and deplete vitamin B12 and make our nerves struggle even more. So if someone has peripheral neuropathy, we need to know this point of interconnectedness. We need to plan for this in our clinical interventions. This is just a small subset, right? I could go on and on this topic, but these are the types of implications. At the School of Applied Functional Medicine, we call it the devil in the detail. The practitioners really need to know, because many practitioners learn protocols in functional medicine, right? You learn this standard approach. If someone has this, do that. If someone has that, do this. But that's a very limited and typically not very empowering approach for practitioners, because the protocol is standard, but there's nothing standard about your patients. Everybody's different. And if you don't actually understand all that devil in the detail about why the protocol works, why is this on it and not that? And if this is not a good choice for this patient, what are my other go-to choices? And how do I know what to choose? How do I know where to begin? This is why at SAFM we emphasize dozens and dozens and dozens of real-life complex case practices, because protocols are not enough. They're not remotely enough to make a practitioner truly capable and truly confident. Sure, it's enough to have some knowledge, but if you want to do this work, if you want to maximize your clinical outcomes, we, on our watch, we want you to be truly capable and confident. So we got to go way beyond protocols to get at all of that devil in the detail, so that you can customize your approach easily to each unique patient. But let's talk about more supplements, because there's some other things that I think are really key. Another misstep that we often see in clinical practice is focusing on one particular supplement without considering what are other cofactor nutrients that you might deplete by recommending high dose of a supplement. Well, so this kind of crosses the line between things that people can readily buy over the counter, but also what you might prescribe. High dose vitamin D, very popular, maybe very well indicated, very effective, but nutrients in the body don't work alone. Almost never does a nutrient work alone. And when we suddenly introduce high dose, especially high dose bolus intake of a nutrient, like, for example, the classic weekly 50,000 IU dose of vitamin D that's often prescribed here in the US. Well, vitamin D does not get metabolized to its final usable form and then broken down from there on its own. Of course, there are a lot of genes that code for enzymes that are involved in the progressive metabolism of the form of vitamin D that you take, whether it's over the counter or in the prescribed form. Well, there are nutrients that are needed for that. And in particular, magnesium is needed for multiple stages of vitamin D metabolism. Well, we already know that magnesium is a common insufficient nutrient. It's less prevalent in our soils today in modern agriculture. If it's not rich in the soil, it's certainly not going to be rich in our intake or in our resulting nutrition. And many people already have marginal, if not deficient, states of magnesium anyway. Stress depletes magnesium because it utilizes a lot of it, but stress also increases urinary excretion of magnesium. So especially here on the heels of a lot of very traumatic pandemic circumstances, or maybe the continuation of that trauma, individuals struggle with inadequate magnesium. Well, you take sudden 50,000 IUs of vitamin D, you're going to increase the demand and the utilization of magnesium dramatically. So people may start to show symptoms of vitamin D intake, but actually they very often are symptoms of magnesium depletion as a result of taking the vitamin D. And this is something we need to look out for. In fact, we teach to replete magnesium status before you begin using more than just a 1,000, 2,000 IUs of vitamin D to avoid that very negative effect that may make someone fearful of using vitamin D. Again, devil in the detail that you need to know. For that matter, vitamin D is also taken up into some of the oldest receptors in human physiology that also requires vitamin A. So we focus on taking really high doses of vitamin D, and we can rapidly use up vitamin A. Vitamin A, an essential fat-soluble vitamin that is especially key for eye health and function. It's also critical for thyroid hormone activation intracellularly. Vitamin A is key also for immune regulation. So you suddenly start taking a whole bunch of vitamin D without a ramp up, without repletion of these interconnected nutrients, and we could begin to struggle with adequate vitamin A. It's already a challenge as we age because As we age, we become less effective at converting the precursor forms of vitamin A, like beta carotene. We don't convert it into the final retinoid forms as readily. So as people age, they may already be struggling with suboptimal vitamin A. Looking for this, right? Issues with eye health or skin health. In particular, people who struggle with night blindness, who say they just can't drive at night because their field of perception or their ability to focus at night and to distinguish contrast becomes highly impaired. Think about vitamin A status. Some individuals genetically just don't convert precursor forms to vitamin A. Anyone who has impaired cellular metabolism, whether it's from hypothyroid function or insulin resistance, for example, or may struggle with making some of these conversions. So this, again, are just nuances that we need to think about. There's a number of things that really came up during COVID that I think we all have got to start looking for in everyone that we serve. What are some things that people have been taking a lot of during the pandemic? Vitamin D, for sure, right? Which again is not a bad thing. It's just the question of avoiding this singular unilateral focus and instead getting into the devil in the detail and looking at nuanced clinical interventions. What about zinc? Lots of people taking zinc on its own. Exactly. Stacy Valine Frost, wonderful point. High dose zinc and maybe with no other minerals. And in fact, we were just reviewing a case the other day, a live case review with our current students. Our program offers 150 hours of real life practical case practice presented by your own colleagues, which is super fun. But this gentleman literally was taking a 50 milligram dose of zinc all throughout the pandemic, and then 4 months ago had decided he was fearful that it may not be enough, so he had actually changed up to a 100 milligram dose of zinc that he was taking 2, maybe 3 times a day. Okay, wow. Hopefully that just made you have goosebumps. It certainly did mine, because it starts to make sense why he has clinically low copper. Of course he does. Zinc and copper compete for absorption both at the gut level as well as the cellular level. And we focus so much on zinc being the unilateral mineral for immune function, but you need copper to make white blood cells. Right? You need copper in order to make stress hormones. You need copper in order to make superoxide dismutase to heal tissue that's been damaged from oxidation by things like COVID. And so this gentleman had clinically low white cell level. This is not a surprise. It's a logical outcome of his supplementation choices. There's actually multiple minerals that compete for absorption. And so, yes, while it makes sense, if you know that zinc is a limiter, we may supplement with a separate zinc, but that needs to be in the context of either a very mineral-rich diet, assuming a person is ready, willing, and able to do that, or maybe they take a separate zinc with one meal and then they take a good multi-mineral with a different meal. So we make sure that we can boost one mineral, but hopefully get rid of the risk of them depleting something else in terms of balance, especially depleting something that just may not be as prevalent in their natural dietary choices, right? If people are eating a standard American diet, it's highly likely they're deficient in minerals, period, because we're eating so many refined, highly processed foods. But for example, someone is eating, for example, a vegan diet, which may suit them metabolically from a macronutrient viewpoint very well. But there are certain nutrients that are just not plentiful in a vegan diet. Just like there's certain nutrients that are not plentiful in a ketogenic diet. There's certain nutrients that tend to be less prevalent in your typical high protein diet, right? They all have challenges and considerations. None of them are right or wrong. It's all about who is this person that we're supporting and what works best for their unique body. And so we want to think about this particular type of interconnectedness. Another key consideration actually during the pandemic and even now is NAC, N-acetylcysteine, hot, hip, popular supplement, right? And absolutely we know from published research over the past few years that a hallmark of damage and dysfunction that comes on the other side of COVID disease, especially if it was a moderate to severe case, is dramatic depletion of glutathione, because there has been just oxidative havoc in the body as debris, wear and tear on the immune battlefield. This is normal. But the body has to heal from that oxidative damage, and it's going to use a lot of glutathione to do that. Well, if your glutathione synthesis capability was already borderline, which, and again, it becomes more depleted as we age, so no surprise that both long haul COVID and more severe COVID are more prevalent as we age. It makes sense that we need support for glutathione, but NAC does not magically transform into glutathione in the body. And yes, NAC does have some properties on its own to support immune function, for sure. An impact on biofilm, an impact on the behavior of some immune cells. But the large lion's share of the benefit of NAC is the body will take that N-acetylcysteine to isolate cysteine as one of the amino acids needed to make the tripeptide glutathione, our master intracellular antioxidant. And if you don't have enough, then on the other side of COVID, you're going to wrestle with a whole ton of different symptoms. And we know in the long haul COVID profiles, it's going to vary wildly depending on what body systems or what body parts were already suffering before COVID. Where was there already a weakness? This is why we have to treat people as individuals, because they need customized support depending on what systems are struggling. We're not going to get to a one size fits all magic remedy for COVID, which is why this type of customized medicine or customized wellness support, COVID, right? Especially long haul COVID is a perfect, blessed place for you to share your gifts and to do this work, because it is largely not being addressed well in conventional medicine at all, because it does not subscribe well to the single solution or the consistent pharmaceutical solution that is the foundation of allopathic care. But N-acetylcysteine is not enough. And in particular, as I mentioned earlier, we need vitamin B6. So you have someone who is on the other side of COVID, they're having long haul COVID, they have a lot of symptoms, they're taking oral contraceptives. Well, what did you just learn they're going to be wrestling with? They take NAC, right? Vitamin B6 may be impairing their glutathione synthesis as well. But what about other amino acids? We need glutamic acid, but we also need glycine in order to make glutathione. And many practitioners are surprised to see, not only in their practice, but also even in the research, just how often glycine can be the rate-limiting amino acid to make glutathione. Glycine as an amino acid is less prevalent in animal proteins than it is in plant-based proteins. So depending on the state of a person's dietary intake, their variety of protein choices, the health of their digestion, which is necessary to denature proteins and then cleave the polypeptide chain so we can actually get at those amino acids to use them in the body, we may not have enough glycine. Well, let's go back to what I said earlier. What if you're taking a proton pump inhibitor that busts your digestion on purpose to get symptom relief from reflux? Well, when you have suboptimal stomach acid, the pH in your gastric cavity is more alkaline, right? It's higher. Then we're not going to denature those proteins as well. And if we don't, think about proteins as being almost like a tangled yarn ball. And you can think about if you have a yarn ball and the enzymes are trying to get in there to break up those proteins, this is a glob, right? Those enzymes are largely on the outside or maybe trying to get into some of the protein folds. It's not going to be very effective, even if you have an optimal level of digestive enzymes. We have to denature the yarn ball so that the enzymes can actually get at those polypeptide chains to isolate them, to allow them to be absorbed. So you take someone, terrible experience with COVID, lots of oxidative wear and tear, they're taking a proton pump inhibitor. Is it likely they're going to get all the amino acids they need to heal from the dramatic oxidative damage that COVID caused without some support? Probably not. And for sure, if they're still suffering with long haul COVID, that's a big giant cue to you and them that they need more support. And so this is the type of things that can actually get in the way. We also need minerals like selenium and zinc, admittedly in trace amounts, but we do need them. And the body will prioritize nutrients for these types of functional balances, right? This underlying normal day-to-day cellular maintenance physiology. But just some examples of what could be at play. Another thing that's actually really become very popular, even in the world of integrative or functional medicine, right? There's all sorts of supplements that can be useful for some people. But let's talk about other things people are wrestling with in long haul COVID. Inflammation, joint pain, right? In general, achiness, which is usually a sign that there's mitochondrial dysfunction, especially if the achiness is all over, and they need good mitochondrial support. And this goes back to CoQ10, because we think about CoQ10 being key for cellular respiration and making ATP, but CoQ10 is really essential actually for antioxidant function in mitochondria to allow for healing on the other side of all of the damage from COVID or from some other infectious or toxic insult. But so we may choose other things. People have joint pain, they have achiness, and so what do we recommend? Well, we got a big toolbox. We recommend things like curcumin, right? Or turmeric, these types of things. That is an awesome supplement idea, but are you aware that curcumin can impair iron absorption in the gut? Well, if you're talking about a menopausal woman or a man that has good iron stores and no sign of iron deficiency or microcytic anemia, you probably don't care. And turmeric is curcumin is an awesome solution for them. But what if you're going back and talking to that woman who has highly debilitating PMS and really depleting menstrual bleeding, right? Heavy blood loss. And so she's having episodic anemia on a monthly basis because of blood loss, and she needs to be constantly regenerating red blood cells. Do we want to choose an anti-inflammatory supplement that risks impairing iron absorption? I don't think so. That doesn't mean there's anything wrong with curcumin. It just means for this person at this point in time, not the best choice. Well, how awesome, because if we've gotten beyond a protocol and we actually have a rich toolbox, we know right away to look for that. We know right away to think, joint pain. Boswellia is a great choice. In fact, Boswellia could be more effective than curcumin, specific for joint pain. And so you choose another tool. This is about customized interventions, right? What about an individual who's struggling with histamine? We were doing a webinar a few months ago, right, where we were talking about the 15 most common disease dynamics you're going to see in your patients who have long haul COVID. Bam, 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 bam. And the importance of really understanding all of them, because almost no one presents with all of them. People present with number 1, 2, and 3, or they present with number 7, 12, and 14. And so we have to know what we're looking for. We got to put the puzzle pieces together for a unique individual, so we're able to make specific recommendations that are way more likely to be effective. Well, one of the most common disease dynamics you see, not only with long haul COVID, but during COVID disease, active COVID disease, people are taking quercetin. Okay, quercetin, awesome natural antihistamine. It actually is a mast cell stabilizer too. Quercetin, great supplement. In fact, it's a great recommendation to people who have chronic nasal respiratory allergies or people who have asthma. Awesome supplement. However, quercetin also affects the enzyme that metabolizes adrenaline, metabolizes epinephrine and norepinephrine. It's actually the same pathway that metabolizes estrogens, that methylates estrogens. So again, who is this person? There's nothing wrong with quercetin. It's an awesome supplement. It's great that it's being so widely used. But if you take someone who already is overloaded with stress, they're having trouble sleeping, they have a lot of ruminating thoughts, they have trouble calming down, they've got a lot of stress-mediated dynamics. Maybe they have hypertension, maybe they have arrhythmia or intermittent tachycardia. They struggle with stress hormones. That's just who they are. Then quercetin is probably not a great choice for them for this particular need. Nothing's wrong with quercetin. Nothing's wrong with this person. It's just about customized intervention. And so we can go to recommend other particular supplements in order to help them from an antihistamine perspective. Maybe looking at things like stinging nettle, in particular stinging nettle leaf, not stinging nettle root, which does something totally different. Stinging nettle leaf has some similar effects as quercetin, but doesn't negatively affect the COMT enzyme that degrades catecholamines, right? The big aggressive stress hormones. Another great solution, pycnogenol, which is a specific type of pine bark extract, is a great mast cell stabilizer. You're going to see a lot of MCAS, right? Mast cell activation syndrome in long haul COVID individuals. Well, quercetin may work very well for them as a supplemental agent as well, but not if their primary disease dynamics are stress mediated. Right? So it's important that you learn these nuances so you can be both capable and confident, because otherwise the other two options are you use it anyway and then it's not as effective as it could be and it may create new problems in a unique patient, or you're afraid of it and you don't use it at all, which is a missed opportunity for the people for whom it could be a perfect customized intervention. And so you can start to see again the essential notion of learning that devil in the detail and having lots and lots of practical real life case practice so you can actually see and have the, oh, got it, that's why that makes sense for this person at this point in time given what's going on. None of us are born knowing any of this, and if you have textbook knowledge of certain pathways or certain protocols or certain supplements, that's awesome. But in our experience over the past 12 years teaching practitioners, it's not enough to help people be truly capable and confident. In fact, it may give us a false sense of confidence that actually is very stressful and overwhelming, because you need to know the devil in the detail. Another area that I want to focus on specifically as it relates to contraindications is, someone asked about it earlier, 5-HTP, right? 5-hydroxytryptophan, which is one step above being serotonin. And even though this is actually covered in the package insert for the medication and often listed as a warning on the supplement box, depending on the brand and the country in which it was purchased, 5-HTP combined with a psychotropic medication that's upregulating serotonin, especially through reuptake inhibition, can actually have toxic effects. And I've seen it done actually really tragically, where 300 milligrams of 5-HT was recommended right on top of a good solid moderate dose SSRI. And within about 5 days, people were showing symptoms of serotonin sickness, which can be really alarming. I mean, it can be harmful for sure, but really fear-making for the individual. But these are things that we need to be aware of. Someone taking an SSRI or an SNRI medication, maybe for OCD, maybe for ADHD, maybe for depression, anxiety, right? We're often, not all of us, but we might be familiar with that. Often, not always, inadequate serotonin transmission may be part of what is at play. I actually think that's less likely to be a major pathway in those disease dynamics, but that's another topic for another day. But if there are issues with serotonin, then for sure an individual may struggle with actually having inadequate synthesis of a neurotransmitter like serotonin. And contrary to common myth, these drugs do not help you to make more serotonin. They don't. They never have. What they do is keep the serotonin that you do have in greater action in the synapse. But of course, the body, as usual, has natural override functions to counter the effect of medications, which are unnatural. That doesn't mean they may not be therapeutically helpful for a period of time, but they are a natural, and the body sees what we're doing and usually is working really hard to counter the effects of the drug. This is why pharmaceutical research is so challenging. And one of the things that it does is upregulates the activity of a degrading enzyme in the synapse called MAO, right? Monoamine oxidase. And so you upregulate MAO in the synapse because you're taking these medications, and then you begin degrading your serotonin and your dopamine at a higher rate than you were before. And so highly likely that you do have need for some upstream additional nutrients to support synthesis of these critical substances. And this is true in a lot of pathways, by the way, not just neurotransmitters and supporting neural tissue. But we have to do it in a responsible, appropriate way. When we know that there's a medication that's going to be very responsive to and aggressively respond to boosts that are one step up in the chain of causality, it's much safer to go farther upstream and to always begin with low doses and to introduce it low and slow so that you can learn experientially how is this person's unique body at this point in time going to respond to this. And so that means you can't support people with things like introductory dose tryptophan or making sure they have enough B6 in order to produce neurotransmitters like serotonin and dopamine. So it sounds like a great strategy to me, right? But again, it's the devil in the detail. I've got 12 more things I want to cover. There's so much to learn. It's why we're so passionate about doing this. I want to talk about two things. I'm going to slip in two. One of them is methylation. So methylation is a hot topic in pretty much any realm of integrative or progressive or functional medicine. We need methylation, actually most importantly, in order to protect our genetic activation, because it's actually methyl groups that are used as markers on histone tails to keep our genes from activating. We need appropriate methylation. We need to not undermethylate. We need to not overmethylate, because we want to have responsive genes to our environment. But we also want to make sure that we are not encouraging genes to activate that we are not going to thrive once they do. And there are a lot of things in our lifestyle that can have epigenetic effects. But we must fundamentally be an awesome supplier. We need to be a champion synthesizer of methyl groups. And many of you are aware of the importance of methylation. You know that in addition to protecting our genome, we need to methylate well to detoxify. We need to methylate well to have hormone balance. We need to methylate well to have good antioxidant function. We need to methylate well to make neurotransmitters. Pretty much all of the underlying fundamental functional balances require methylation. Well, methylation requires nutrients. And it requires nutrients like, the B6 we spoke of earlier, that's likely to be of suboptimal status in people who are using oral contraceptives. Like B12, that's likely to be depleted in people eating a vegan diet or using a proton pump inhibitor or taking metformin. And I'm focusing on these things because when we think about methylation, so much of the blogs and the videos and the things that practitioners and educational institutions share about methylation, it's all about folate. Folate is the celebrity B vitamin, right? B9. But here's the thing. Folate alone doesn't do diddly toward methylating. No nutrient acts alone. In fact, it's actually B12 that escorts folate to the methylation party. And so it doesn't matter how well dressed you are and suitable for the party. If your escort doesn't show up, you're not going. So these are simple, fun stories and analogies you can teach your patients and clients about why that high dose folate supplement they're taking is not enough to help them methylate well. That's why their homocysteine isn't budging. That's why some of their neurological challenges aren't getting better, right? We have to supply the cofactor nutrients that are needed. And we need to be thinking about where does an individual need more support for methylating. right? And we can use things like homocysteine, not as a perfect, but as a marker of this, some marker is better than none, so that we can better understand what individuals need, right? Even if we're bringing on enough B6 in our diet, right? And maybe we're not depleting it with medications. You need enough riboflavin, vitamin B2, to activate vitamin B6 to its final form so it can actually be used in some of these pathways, right? Well, how often does riboflavin B2 come up in conversations about methylation? Not very often. And for that matter, we need methionine to methylate, period. And methionine is an essential amino acid that you must get from dietary proteins. Well, people who are eating more of a junk food diet aren't necessarily getting enough protein. That may sound crazy because we think so much that people will be getting plenty of that. But a lot of the people in your practice is eating a standard American diet are eating things like donuts for breakfast, pasta for lunch, and pizza for dinner. And there may not be a lot of protein involved there. It may be a lot of chemicals, a lot of calories, a lot of fat, and unfortunately not the right kind of fat, and lots of refined glucose spiking grain flours. And so we don't want to assume people are getting enough protein. This is why an awesome intake session with a good dietary review is so essential. People may say, oh, I eat things like this or that, but that may be the exceptional learning, not their typical actual intake. So it's important that we're getting enough of all of these things in order to methylate well. And if people have genetic impairments in methylation and their homocysteine is really high, there's also cool other pathways, right? Something I call the choline bypass, right? Where in certain tissues, like in the liver, which especially needs to be a champion methylator, you can use other nutrients like choline to bypass the need for more folate and B12, which won't help the systemic body, but for sure it can help certain tissue. Let's say you've got someone with high homocysteine and fatty liver who's flirting with type 2 diabetes. Choline sounds like a really awesome solution for them in their unique body at this point in time. So much bioindividuality is at play. The last thing I want to mention, let's talk about anxiety for a second. A lot of people struggling with anxiety. When you feel terrible with long haul COVID, that's a very anxiety promoting situation. You may have lost your job for a variety of reasons during the pandemic and you're not remotely returning to normal. You are anxious. You lost your business, you lost your job, you got fired from a career you loved. There's a lot of post-traumatic pandemic suffering, right? That people are really struggling with, that we have to be present for. And this may affect people with financial concerns and professional concerns and family responsibility stressors and all sorts of things. Families that are still torn apart, who won't spend time together or don't feel like they can. And so the effects of the pandemic are far from over, my friends. And I am seeing more and more, yes, the 15 disease dynamics I mentioned, but one of those has to do with stress, anxiety, panic, right? And people who are still living in primarily a sympathetic nervous system mode. It's so important that we are present for them. Lots of people are not sleeping well these days, not because they don't have enough melatonin and not because they can't make enough melatonin from their serotonin. That's all good. Their cortisol levels are all good. If you supplement with those, it's not going to help them because that's not actually the root cause of what they're wrestling with. But instead, what they've got is a hyper-vigilant, ruminating mindset. They often are struggling with an imbalance in GABA and glutamate, the two primary neurotransmitters that are affecting more the overall pace of neurotransmission. And we only sleep, melatonin is only able to work when we make enough GABA to calm neurotransmission overall, to just calm the din in the mind, calm the noise, that relentless voice in the head. We have to calm it enough for melatonin to be able to work. And what matters a lot for this? Things like sleep hygiene, right? What are people doing in the hour or two before sleep? It matters hugely. Do they have a square of dark chocolate after dinner? That may actually be a problem. It would make much more sense for them to have it maybe after lunch. Are people having a second cup of coffee at 2 or 3 o'clock in the afternoon? And yes, it is interfering with their sleep. They may still be able to fall asleep, but they sleep fitfully or lightly, easily awakened. GABA glutamate imbalance is really essential. Well, what do we need in order to promote good GABA glutamate balance? Well, we need vitamin B6. I'm not making this up, my friends, right? And I'm just talking here. I could talk for days, literally. We're talking about a certain cluster of nutrients here. We could pick a different cluster and have just as much fun talking about the fascinating interconnectedness. You need B6 for good labile movement between glutamate and GABA. You need magnesium, right? This is something that is supported by taurine. And to make taurine, you have to methylate well, right? All of these things matter because they're upstream in the chain of causality. Upstream in the chain of interconnected physiology and biochemistry, that is a very logical reason why this person is suffering with this thing at this time. And that does not have to be overwhelming. You can get to the place where you legitimately feel like, I'm good, I'm super excited today because it doesn't matter who walks into my practice, I know I can help them. And there is no better feeling as a practitioner, right? Certainly the work may be challenging, right? You know, certain individuals may be challenging because we got to be creative at how to help them. Certain cases may be challenging because we got to dive into the detail. They're challenging, but they're not daunting. They may be challenging and fascinating, but they're not overwhelming. And when you don't feel overwhelmed and you don't feel daunted, then you don't burn out. You're not exhausted. And this work is fun, crazy super fun. And you get the deep professional fulfillment and personal satisfaction of knowing you're helping people that the vast majority of medicine is not able to help actually get to the root causes. You're able to help people who've often been suffering for a very long time and have almost given up hope. You're able to help people who maybe have become hopeless. Who otherwise the logical outcome, unfortunately, in allopathic care is they're going to end up with 6 to 10 meds addressing 6 to 10 symptoms, and their disease process is worse, not better. Are they getting some relief? Yes. And is that better than nothing? Absolutely. Way better than nothing. But it is not remotely close to the best we can do. And the sooner we all hold ourselves and one another, all of us in this kindred spirit community, to a higher standard for what is possible in healthcare, and we actually don't just talk about it, we do it, we prove it through results, the sooner we'll all be a part of a different system that actually embraces this possibility rather than just constantly questioning it and challenging it. Because there are success stories through the functional medicine lens everywhere. I thank you for being here today. Have a great day.